Hello, my dear colleagues in Latin America. I'm really so sorry I'm not there with you, but this is such an immense pleasure and an honor to bring to you this lecture on advances in the design of stents and PCI, especially for those patients in diabetes. Let me first begin by sharing with you my disclosure specifically to my institution for the work that we do in our academic research organization, where we run clinical trials for device and pharmaceutical companies. But also, let me remind you how important diabetes is. The global prevalence of diabetes mellitus is on the rise. There's no question about it. And it's not just in the United States, but it's across the world. And the number of people living with diabetes has almost doubled over the last decade. And it seems to be going up higher and higher as we begin to have better ways of measuring even the pre-diabetic patient, but also understanding and collecting these data. There are 1.5 million deaths caused by diabetes alone. And this is something that we need to absolutely consider, that 1 in 11 persons will have diabetes in their lifetime. And this is not something to take lightly. Because of the very, very important close relationship of diabetes and coronary disease in the pathobiology of how hyperglycemia, insulin resistance, and free fatty acids have had clear associations with endothelial dysfunction, platelet activation, thrombosis, smooth muscle cell, vascular smooth muscle cell, proliferation, migration, apoptosis, and of course, increasing plaque complexity and changing, in fact, the remodeling processes. These are all associated and very much result in increased coronary artery plaque burden and plaque instability in patients with diabetes. In fact, we're seeing very clearly that diabetic patients have more complex coronary anatomy. Their vessels are smaller, diffusely diseased, negatively remodeled, and we see more necrotic core volume, more inflammatory infiltrates, and more calcifications. This makes these vessels very, very difficult to treat. And as you know, our stent technology doesn't do very well with diffuse calcific small vessel disease. As it relates to both acute myocardial infarction and death from any cause, we see that diabetic patients, especially this is from the Swedish National Diabetes Registry of over 1.3 million patients, you see those patients with elevated glycosylated hemoglobin have the highest mortality from any cause, as well as increased mortality after an acute myocardial infarction. Now, what have we done in treating patients with diabetes? The best is earlier diagnosis, optimal medical management with a very important dealing with both target vessels and also non-significant stenoses when these patients present with coronary artery disease. And in fact, we know that at the moment, for those patients with multivessel disease and diabetes, coronary artery bypass surgery is very, very important and does have an important advantage over percutaneous coronary intervention. As you can imagine, bypasses, especially with arterial bypasses, you do have, bypassing the entire vessel, not just treating a lesion. And we know that diabetic patients have non-culprit vessels and lesions that progress and could have recurrent restenosis, etc., and of course, requiring multiple procedures. And of course, very, very important as well is the fact that total arterial revascularization has been somewhat questionable in diabetic patients because they have more infections, especially with more both arterial REMA and LEMA used for bypasses. So you can imagine there is a dilemma in treating these patients. But the optimal guideline-directed medical management has been improving. First of all, very importantly, is the control of the glucose, and the current agents, some of them have some of these pleiotropic effects that may not at all be related to cholesterol, glucose reduction or control, but rather to do with cardiovascular mortality. We've seen this with SGLT2 inhibitors and even some of the GLP-1 agonists. And of course, we know that we have to be extremely vigilant about their other risk factors, such as hypercholesterolemia, with bringing the LDL down as low as possible. We now have really important targets and ability to use drugs like PCSK9 inhibitors and the antithrombotic therapies that most likely are working for these patients. And I think, again, we have this dilemma with patients with diabetes because of the fact that we only have so much to push the antithrombotic regimens, but we have to be thinking about coronary revascularization, even with the best advances in pharmacotherapy, because they do have a lot of events due to coronary events that we need to be vigilant of. In fact, if you look at the 25 years data from the Berry trial, because it's been 25 years since then, and if you remember the data that was presented of the 6-year, the late data, showed CABG to be better than PCI, but there's so much that has gone on since Berry 25 years ago. And of course, we have to rethink that, are there better ways that we could treat these patients? The Freedom trial presented in 2012 really did show in 1,900 diabetic patients that there was a reduction associated with assigning patients to bypass surgery when there was equipoise between bypass and PCI. And here the PCI was with first-generation drug-eluting stents, but still mortality benefit for CABG. And at the moment, our guidelines are telling us that multivessel disease, diabetes, patients need to be offered bypass surgery. And I think this is really, really important. In fact, we have now follow-up studies with Freedom still showing a benefit of CABG in terms of probability of survival. Very important to see that these patients with multivessel disease, CABG lowered the all-cause mortality with compared to first-generation drug-eluting stents. So over the last 20 years, we have really seen that currently with our PCI technology, we're at a suboptimal place in treatment of patients with diabetes and who present to the cath lab. And in most cases, we are really referring a lot of these patients to bypass surgery. And I think if you think about this, we have to be imagining that so much is going on that we need to kind of think about the patient as a whole, and that diabetes has effects on the kidney and on the inflammatory process and even on myocardial dysfunction on its own. And of course, restenosis and stent thrombosis, which are the two very important issues for patients who have stents, is something for us to absolutely think about because of the rates of restenosis and stent thrombosis being higher in our patients with diabetes. So is there any way over these years, has there been any improvement in PCI technology to at least give the patient a lesser invasive approach, or perhaps the first approach for some of the diseases compared to bypass surgery? Well, yes, there has been. There's been huge design progress in metallic DES, and we see this over the years with less strut thickness, changing of the polymer material to be less inflammatory, and now really going to a different either everolimus or sirolimus analogs that are now being used as the anti-proliferative drug rather than paclitaxel. And I think where we are from bare metal stents to first generation, and no question that the second generation has shown some less restenosis, less thrombosis, and much better mechanical performances. But what about in diabetes? Have they made that important impact? Well, restenosis has decreased, but has it gone to the point that we can say we can go up against bypass surgery with the same level of enthusiasm? And I would say that perhaps we still need more data before we say yes, because while stent thrombosis has been much, much lowered, below 1% over the years, we have to kind of think about where we are now in terms of what is the best possible result for diabetic patients. And here in the Tuxedo trial with the second generation DES Xience versus Taxus, there was a significant improvement in target vessel failure and target lesion revascularization. Most of this due to less restenosis, as we would expect. We also know that Xience stent, this particular generation drug-eluting stent, has been associated with very, very low stent thrombosis rates. So should we now go back and question the results of Barry 2D and Freedom because we have a better comparator for our drug-eluting stents? Well, maybe, maybe not. Here's data from the New York State Registry where we're seeing that mortality is certainly no different with comparing CABG to PCI. But remember, these are registries, observational trial studies, a lot of confounders, and it's difficult to make that ascertainment. We're seeing more stroke, but I would not be going, and I'm certain that bypass surgery most likely is overcoming the non-stented lesions in terms of bypassing the entire vessel, because we're seeing higher myocardial infarction with PCI, and of course, completeness of revascularization being a very, very important issue that helps equalize the playing field. And we see that in the everolimus-eluting stent arm of the New York State Registry, it was those who were incompletely revascularized where there was most of the effect on myocardial infarction. We also have seen very interesting studies from the newer generation drug-eluting stents. This is a biodegradable polymer sirolimus-eluting stent where we're seeing actually an improvement with this sirolimus-eluting stent compared to Xience. 1/3 of these patients were diabetic. It would be really interesting to see whether that effect was seen. There was no interaction. You see that diabetic and non-diabetic patients did very, very well against the Xience stent. So BioFlow, this next generation of stents, may have some interesting advantage even over the Xience stent. Obviously, we need much larger. We have so much data on Xience, and this is sort of a very, very interesting new technology that we need to look at. We've also seen other stents like the polymer-free Create stent, compared to the BioFreedom stent in the study that was presented. And you can see here of the 1,280 patients from registries, propensity score matched analysis showed some improvement in our diabetic patients favoring the Create trial, and hence begging the question that is it this particular stent that could have some interesting technology with its amphilymus elution that could give us a advantage for our diabetic patients. And in fact, in their sugar trial, they showed against the zodorolmus-eluting stent a superiority for target lesion failure, mostly driven by their target lesion revascularization being lower in Create versus Resolute. There's also another stent technology that is worth a mention, and that's the Abluminous DES. This is a novel abluminal-coated sirolimus-eluting stent, 73 microns with a biodegradable polymer and coating that's on the abluminal fusion coating on stent, and also parts of the exposed balloon. And the interesting technology that's being shown here, and the novelty of this is the fact that the drug and the polymer are basically applied after the crimping over the balloon, so you're getting this homogeneous sort of elution all the way into the vessel wall on the abluminal side, and a very, very good and controlled drug release up to 48 days. So as you could see here with the abluminal surface sirolimus in a biodegradable polymer matrix, and you're getting both a DES and almost a drug-coated balloon, if you could see, because of the coating that allows the being done post crimping, basically also exposing the balloon as well, the parts of the balloon that you could see here in between the struts as well as the edges of the stent. And the abluminal coating could also have some influence on re-endothelialization that we have to know. So if you look at this with the current technical specifications and what we're seeing here with Abluminous DES, we're hoping to have a uniform coating layer with a faster re-endothelialization, as well as thinking about that focal restenosis that occurs on the edges because the balloon edges are also being applied the drug. And this absolutely requires a prospective randomized clinical trial, because even if you think about how you might be dealing with diffuse proliferative disease in diabetic patients, and even in AMI patients, this could have some interesting advantages for diabetic patients with a homogeneous elution of the drug, sirolimus. The preclinical experience has been fantastic. The polymer looks good. There's hardly any inflammatory changes associated with it, and we're seeing really, really good drug delivery and inflammation scores. But always the answer is in a large-scale randomized clinical trial, which we are absolutely performing right now, almost near the tail end of this trial, with about 100 patients to go. We're up to 2,900 patients enrolled in the Ability Diabetes Global Trial. This is a prospective randomized clinical trial in patients who present for a percutaneous coronary intervention and have diabetes. And the randomization control would be the Xience everolimus-eluting stent system. We have over 100 sites, 20 countries in Europe, Asia, Australia, Latin America. I'm proud to say that Latin America is leading the pack, with the Brazil being the #1 country. And we're very, very excited to bring this forth. Our primary endpoint is target lesion failure, TLR powered for non-inferiority, and sequential superiority, and target lesion failure powered for non-inferiority. These are the two co-primary endpoints. It's diabetic patients eligible for PCI. We have follow-up all the way to 24 months on a 1-to-1 randomization with a single blind for follow-ups, as well as, of course, complete adjudication and data safety monitoring board, etc. So as you could see, these are patients who meet the criteria of having at least one de novo coronary artery stenosis, the stent diameter of 2.25 to 4.0, and we're excluding ISR and bypass grafts. This is really de novo, and you have to have diabetes, eligible for PCI, and of course there's randomization to the Xience stent. And you can see again, these are diabetic patients, chronic stable angina, silent ischemia, and ACS. We've been all ever so inclusive, and really want to make sure these patients do have diabetes. These are not pre-diabetic patients. These are diabetic patients with hemoglobin A1C levels greater than 7. We are including those patients with previous PCI only with balloon angioplasty if performed over 12 months after the index. We don't want ISR. And of course, we want the vessel sizes of 2.25 to 4.0, and of course, eligible for PCI. We are excluding shock, planned surgery, anyone with STEMI or a life expectancy less than 12 months, or anyone with acute or chronic renal dysfunction over creatinine over like 3. ISR and lesions in bone grafts are excluded. I've already talked to you about the study endpoints, 2 primary endpoints of ischemic TLR with a powered non-inferiority and sequential superiority testing, and T-target lesion failure, which is a composite of cardiac death, target vessel MI, or ischemia-driven TLR powered for non-inferiority. And you see these are the secondary endpoints as we would be looking at. As I said, we're already at about 2,900 patients enrolled in June. We had at 2,549. This is August. We're up to 2,900 patients. We have an amazing, amazing team. And I think we're looking forward to having the results in a couple of years to all of you. Hopefully, we'll present some of that at SOLACI as well. And just to bring this home now, I hope this presentation has reminded you of the importance of the epidemic of diabetes around the globe and how we as clinicians taking care of and the cardiovascular disease specialists will be seeing a lot of diabetic patients, and increasingly so. In fact, when they present with CAD, they have more complex disease, they have high risk of recurrence, and many other comorbidities. We have the best possible optimal medical management for these patients, and we have to push that to the highest level. And unfortunately, SGLT2 inhibitors that are saving lives are not being given to these patients as they should. And in fact, we've seen also on the coronary revascularization side that our drug-eluting stents have not done very well. Certainly not the Bear stents, certainly not the first-generation drug-eluting stents, and even with the second-generation DES, we are seeing some recurrent rates at the moment. These novel technologies that are looking for these higher-risk patients, like diabetic patients, are ones to watch out for. We've already seen the CREATE stent doing well. We'll see the 2-year data, I hope, very, very soon. But also, let's understand that an ongoing abluminous DES, very well-powered 3,000 patient study, which is the largest study in diabetic patients undergoing PCI, is right now underway, almost 100% enrolled, and we look forward to sharing those data. So I hope the future will be bright for these patients, and certainly we absolutely have to get our arms around diabetes as we go forward. I want to thank you for your attention, and I look hasta luego, and I hope to see you very, very soon in person. Thank you so much for having me there.